Welcome in, folks who are joining us. So good to see you. Please come on in and get settled. If you'd like to introduce yourself in the chat, we'd love to hear where you're coming from, what you're up to. We welcome you into the event, and we're just going to get settled briefly before we get started. Okay. All right. So folks who are attending, you will know that we have an audio for you to hear us. However, you will be muted for the portion of today's event just because we have so many incredible speakers. So we welcome you to please use the chat as your way of communicating. You can chat with everyone. You can send messages to specific people if you have questions for specific speakers. We welcome you to introduce yourselves like we just mentioned. You can call in via your phone or you can use your computer audio. Those both are available under audio settings as well. The chat is there for you to utilize along with a Q&A box that we'll be utilizing throughout. We really ask folks to put their thoughts and their comments into the chat and then save. If you have real questions that we want to put separately, we ask you to put those in the Q&A box so that everyone can see, and you can upvote questions. If you see one that you really want to get answered, you can feel free to add that into the Q&A box as well. Captions are available by clicking the closed caption icon at the bottom of your menu. And if you have any other questions, please send me a direct message. My name is Leila Cardi. I'll be the tech support lead today. So if you are experiencing any issues, please let me know and I will be answering as soon as I can.
Lee, it looks like the chat is disabled for some people.
Oh, okay. Let me get onto that and I will pass it now as I've done housekeeping. I'm going to pass it over to Wendy White-Taggreen for our agenda today.
Hello, everybody. We are so delighted that you are with us today. This is our second Sparking Recovery event that is going to begin to be held quarterly. And we wanted to go ahead and share the agenda with you for our time together today. This is a 90-minute session to allow us as participants and you as webinar participants to dive deep into some recovery work. And we're going to give you some more context for the whole of the event in just a moment. But we wanted to remind folks that today we are going to be focusing in on recovery-oriented systems of care. And so after I provide a little bit of introduction to content and let Samza speak to kind of the role and the initiative and the drive behind Spark, we're going to move into that deep dialogue about the recovery-oriented systems of care. We'll have a brief audience poll. Then we have a roundtable response. So folks who are recovery leaders, we have 3 extraordinary leaders who are going to spend a few minutes remarking and responding to the content we have heard today and give reflections based on their lived lens. Then we're going to move to some standard updates. So we hope for any of you who are now participating the second time, you're starting to see a trend in kind of our agenda set up. So Samza will come back on and provide Office of Recovery updates. Then we will pivot to NASHBID, the National Association of State Mental Health Program Directors, for updates, and then wrap up with closing remarks. So I do want to just make one editorial note. When we met last, we had, again, this is a very new initiative. Spark is a new SAMHSA initiative. We've had one other quarterly Sparking Recovery event, and that was in May. And at the time, we believed we were going to be talking about workforce for the second event as well. But since that time, we've activated an amazing planning committee who are all peer and recovery and lived lens leaders across the country. And that planning committee really kind of focused in the work and shifted the initiative for today to recovery-oriented systems of care. So if you walked into the meeting thinking there was going to be workforce today, we just wanted to go ahead and be sure we denoted that is largely because when we kicked off in May, we thought we would do 2 back-to-back on this, but are delighted that the planning committee has activated and that they are amazing leaders and are guiding the process for us and for SAMHSA. And so we are focused on ROSC today. So next slide, Lee. So to kick us off, I'm gonna turn the microphone over to Michael Askew, and he is the Deputy Director of the Office of Recovery at SAMHSA, the Substance Abuse and Mental Health Services Administration. And in that role, they are providing, managing and providing leadership to all of SAMHSA's overarching mission and vision. And under the Office of Recovery, specifically looking at evaluating and initiating policy and programs and services and dialogue and conversations like these today with a recovery focus, and specifically lifting up the voices of individuals in recovery and being sure that they are globally represented in all of the work of SAMHSA. So it's my pleasure to introduce to you Mr. Askew today.
Well, thank you, Wendy. It's an honor to stand here and be able to provide opening remarks. So good morning and to those that are from the West Coast, but good afternoon to those that are joining us from the East Coast. I am not only the Deputy Director of the Office of Recovery at SAMHSA, but I'm also a person with living experience and was formerly incarcerated as well. At SAMHSA, we see and understand the necessity and importance of recovery and recovery-focused, oriented, and centered approaches. This led to the development of the SAMHSA's Office of Recovery. And in September 2022, we launched the Office of Recovery that brings together the voices of our mental health and substance use communities to drive the overarching goals and objectives of our work. We have a dedicated team of people with lived experience, family members, and allies with a deep understanding of recovery. And we are charged with promoting recovery and recovery support services at SAMHSA and across the nation. Our goal is to advance recovery and recovery support services for mental health and substance use conditions and ensure they are available to all, regardless of age, gender identity, sexual orientation, race, ethnicities, ability. Our office forges partnerships, including Spark, to support all individuals, families, and communities to pursue recovery, build resilience, and achieve wellness. And we're doing this through SAMHSA's National Recovery Agenda, inclusion, nothing about us without us, to foster meaningful involvement in improvements of behavioral practice and policy, equity, making recovery supports accessible to all, including underrepresented and underserved populations and communities. Peer services, peers helping peers and expanding peer services in every community. Social determinants of recovery, promoting whole person care to address key social determinants that support recovery as housing supports, employment supports, community, education, purpose, and others. And finally, wellness, enhancing health and behavioral outcomes by implementing holistic strategies that support people to live longer, healthier, fuller lives. With SAMHSA, our partners, our communities and programs, and you working together, we can meet the above goals and further recovery for all. With these goals in mind, SAMHSA has launched SAMHSA's Program to Advance Recovery Knowledge, known as SPARK, a national TA center operated by the Office of Recovery with support from the Center for Substance Abuse Treatment. The goal of SPARK is to advance recovery-oriented systems of care across the nation for people with mental health and or substance use conditions. Spark supports transformational recovery-oriented change for every state, tribal, and territorial behavioral health system, promoting equitable access to recovery supports. Spark's key priorities align with SAMHSA's are inclusion of people with lived and living experience to formulate solutions, to ensure equitable recovery supports are equitable and accessible to everyone, the need for equity for minoritized and historically and systematically marginalized communities, the delivery of authentic peer recovery supports, and the importance of addressing social determinants of health and recovery. Spark is primarily run by C4 Innovations with a team of outstanding national partners, which includes National Association of State Mental Health Program Directors, the Alliance for Rights and Recovery, the National Council on Mental Well-Being, Faces and Voices of Recovery, Advocates for Human Potential, and the Center for Applied Research Solutions, as well as other consultants and subject matter experts that work together to further the previously mentioned goals that we set forth. We are so excited that you have joined us today to be part of the Spark community. And now, without any further ado, I will pass the mic to Ms. Wendy White-Tygreen. Wendy?
Thank you so much, Michael. We are just delighted to be here working in partnership with SAMHSA and all this amazing and extraordinary community in advancing recovery. So next slide, please, Lee. So we're going to just talk for a second. Again, we're trying to set the stage for creating community, like a recovery community among us here where we're all learning. And so we want to just reintroduce the framework very briefly at this onset. So again, here you see the SAMHSA priority areas that Michael Askew mentioned and that we've been anchored around collectively. So you see the 5 strategic plan priority areas at the top here that are then lay as an umbrella for dimensions of recovery that are talked about and mission focused under SAMHSA. And those areas are health, home, community, and purpose. So those are the drivers and the lens through which we are all looking at this work collectively. Next slide, Lee. So under those dimensions of recovery, then we began working with SAMHSA in partnership with them to lay out this framework, which is there's some significant cross-cutting themes that span health, home, community, and purpose. And there are things like equity, workforce, co-occurring conditions that folks may be experiencing, social determinants of health, or using the new term that our federal sister agency CMS uses, health-related services, social needs. So those things are kind of cross-cutting. So then the team decided on a model which really then contemplates the implementation of how we should be looking at a whole of government approach. And so in looking at whole of government approach, we're thinking about what's a national lens, kind of what's a state lens, and what's a local lens, and how do we approach dialogues of elements and themes in the cross-cutting red arrow, where then we can work together to implement some strategy on accomplishing some big goals on this work together. So we're having quarterly Sparking Recovery events, but then we are having federal agency dialogues to take the content, like today, ROSC, and then to think about with other federal partners how we might share more information about ROSC with federal interagency leaders, and then contemplate technical assistance strategies which may be necessary to advance things like today, ROSC, recovery-oriented systems of care. So that would be like a snapshot of a quarter where we're taking kind of a theme like ROSC, and we will continue to talk about it over the next quarter while simultaneously planning the next quarterly Sparking Recovery event, because we want to see deep change as we have these conversations. Next slide. So again, the whole of government lens we already mentioned, but I would like to just hover here on what our foundational community norms are. And as we begin to come together quarterly like this and invite hundreds of people together, right? I just want to name some norms for the group. So in the chat, like that's establishing community, like lean in, talk with others, but do so with respect and honor of all the different types of folks who are going to be in our community today during this hour and a half and then ongoing. Be mindful that we are talking mental health and substance use inclusive. Recovery spans mental health, substance use, as well as other healthcare conditions. But for this purpose in this group, we're really thinking about it for both mental health and substance use. So broad inclusion and be mindful of person-centered language, respectful language. And then also, and we're going to try to do this as well, is to be sure to like spell out acronyms and being sure that we're all collectively learning and coming together to the same platform for this conversation. So next slide. So with that, we are going to get into the meat of the conversation today, and it is my honor to launch the this set of speakers who we are going to have that are going to reflect on some national, state, and local perspectives on recovery-oriented systems of care. And so with that, I am going to begin the handoff by giving the mic to Spencer Clark, who is a social worker. So I'm loving that as an MPW myself. And he is with SAMHSA, the CSAT office. And we are just so glad to have him today. And Spencer, please take the mic.
Thank you so much. It's a real privilege to be here today and to share an opportunity during National Recovery Month talking about SAMHSA's outstanding support for recovery. My particular niche in CSAT is with the Substance Use Prevention, Treatment, and Recovery Services Block Grant, which is the primary source of funds for many states, territories, and one tribe to provide services that range across the entire continuum: prevention, harm reduction, treatment, and recovery services. The block grant is a little over $2 billion that's awarded annually to 50 states, District of Columbia, 5 U.S. territories, 3 freely associated states in the Pacific, and the Red Lake Band of Chippewa Indians. The block grant is somewhat unique in that it provides really opportunities for states to meet the needs that they determine are most pressing in the entire continuum. Generally speaking, the recipient of the block grant funds is a single state agency. They in turn subcontract with subrecipient organizations, administrative service organizations, faith-based groups, and so forth that actually do the actual delivery of services. Block grant funds are, one of a variety of funds. We are pleased that the block grant can support things that range, as I said, from prevention through treatment and recovery support services. And it's, of course, intended for individuals that don't have something called health insurance or other coverage for their services. So these services are available to individuals irrespective of their particular income status, and we try to provide a kind of a welcoming atmosphere for that. On a kind of pragmatic basis, the dollars we have are very generous. The Congress, particularly during the pandemic era, have provided unheralded funds for us that we have applied to the states, and the states have done some extraordinarily unique things both during and after the pandemic, in the space of both treatment and recovery. The particulars are that the annual appropriation for the block grant is usually around $2 billion, but we received some extraordinary funds in FY21 that continued through the September of 25. These were called COVID-19 and ARP supplemental funding, and the states right now have about another 12 to 15 months to earn the remainder of those dollars. So this is a particularly opportune time to be bringing these dollars to the forefront in an era in which the Congress is increasingly providing very overt support for recovery services. Some of you are aware of the fact that the Consolidated Appropriations Act of 2023 actually changed the name of the block grant. The block grant was previously referred to as the Substance Abuse Prevention and Treatment Block Grant, and the authorization changed back in 2023 to be called the Substance Use Prevention, Treatment, and Recovery Services Block Grant. This was no small enactment. This was something that had been really studied and really supported for many years, and we're very pleased that the Congress passed this legislation back in the waning hours of 2022, and it of course is our statutory language now going forward for 2023 and going forward. This expanded the authorization for recovery support services and really also expanded the opportunities for states to tell us more about what they are doing. The block grant has traditionally supported recovery in lots of ways, but that has not really accounted the types of services are provided, the number of recipients, et cetera. So this has all changed since the Consolidated Appropriations Act. And now all states, all grantees for the block grant are, both that receive these funds are reporting to SAMHSA on a regular basis about the use of these funds. In 2023, we were very pleased that SAMHSA embraced a very robust suite of services, recovery support services, for the expenditure of block grant funds. This has been a question for a while, and SAMHSA rose to that task, and we adopted a set of 14 services, and I'm going to cover those very briefly today. They are available, of course, on our website that explains in detail these services that are referred to as allowable recovery support services. And this was actually done in combination with the Center for Mental Health Services, who also were adopting a suite of services that are really attempt to cross the entire range of the continuum of care. The particular services that have been adopted that are now a part of the Substance Use Prevention, Treatment, and Recovery Services Block Grant include the following: peer-to-peer support for individual services, peer-led support groups, peer-led recovery educational workshops or events that are quite varied in nature, recovery, health, and wellness education activities, culturally based recovery practices, and creative and expressive arts recovery. We are trying to do a better job, as Michael pointed out earlier, of meeting people where they are and bringing to bear our support of a variety of ways of approaching recovery and supporting recovery. These include recovery social support, social inclusion activities. Most importantly, recovery community organizations and recovery community centers are supported with these funds. And then one that we have been really proudly supporting for a number of years now is recovery housing. We know that housing is a must for many, many individuals who are seeking or receiving services, and we're very pleased to be able to support our recovery housing organizations who really add housing as a critical component of recovery. Other areas include high school and collegiate recovery programs, recovery-friendly workplace initiatives. And then, of course, we are also trying to make sure that when parents or individuals are having challenges with childcare or transportation in order to receive treatment and or recovery services, we can support that with our dollars as well. The last activity I'll mention is, of course, peer-led training and peer certification activity. These are both activities we really need to grow, embrace, honor, and support this workforce coming from a peer perspective. And these are activities that we are very pleased to be able to support with these funds. I think I'm gonna just mention there that the Assistant Secretary has placed this as one of the very highest priorities that we have during this administration of making sure that we utilize the opportunity with both our standard block grant funds and these COVID-19 and ARP one-time funds to provide all kinds of support that I've mentioned for recovery. Right now, the organizations that can provide these services are subrecipients to the single state agencies that I've mentioned. We're eager to hear your ideas, to look for your questions and your concerns, and the innovative things you want to do with these funds. This is really a pivotal time right now for the block grant and for recovery, and we are very pleased to be a part of this solution. On that note, I will turn it over to Dr. Achara. Thank you.
Thank you so much, Mr. Clark. It is for someone like myself who has been working to advance recovery-oriented systems of care for over 20 years now. It is just so amazing to hear the extent to which SAMHSA is fully supporting the wide breadth and scope of services that systems throughout the country need. Just tremendously exciting and gratifying. So thank you for that overview for us. That was really helpful for me and really exciting. So my experience, I come to this work as someone who has worked in both state and city government and who's really, really passionate about just advancing recovery-oriented systems of care. And I am starting today with just kind of helping to frame us and ground us in what this concept, what are we actually talking about? Because one of the things that I have found over the last 20 years is that there are a lot of misconceptions about this whole concept of ROSC, and that it tends to be so kind of ambiguous and ethereal and out there that it can be hard for us to kind of wrap our heads around what are we actually talking about when we are referring to a recovery-oriented system of care. So I am so honored to be here with you today. All of these amazing recovery champions around the country, 155 of us, that's like cause for celebration. I'm so excited about that. And I'm just gonna ground us for a few minutes in like big picture, what we mean by a ROSC, and so that you have that kind of larger context and umbrella for the rest of the speakers, the context that they will share about. So when I think about a recovery-oriented system of care, I think two things come to mind for me initially. I'm thinking about a different purpose for a system. I think about a system that is trying to accomplish something that is different than our traditional systems. And one of the first things I think about is, as a person who's originally trained as a psychologist, all of my focus in my training was on helping people manage their symptoms, get control of their symptoms, get to a place of wellness was considered that people had either no longer were experiencing symptoms or that they were stabilized. And in a recovery-oriented system of care, it is so much bigger than symptom management. We are focusing on helping people not just manage symptoms of, depression, anxiety, or substance use. It is about how do we put the services, supports, environments, opportunities, connections in place for people to thrive. And so a recovery-oriented system of care, from my perspective, the purpose is different because we are moving beyond symptom management, we're moving beyond stabilization, and we are really looking at what are the breadth of community services and supports that people need to flourish and really experience true community inclusion. When I think about a ROSC, I also think about that we are not only adding recovery support services to the existing system, that we are really thinking about how do we transform the very nature of all parts of the service system so that every part of the service system is aligned with recovery-oriented values, a recovery-oriented approach. So we're not just adding the breadth of recovery support services around and within the existing system. We are actually changing the actual focus and how the service system itself functions. So I will give you an example of what I mean by that. I have a 10-year-old daughter, Sage, and just within the last couple of years, Sage has begun to experience some mental health challenges, and particularly a lot of debilitating anxiety. And we were doing therapy. Therapists recommended that we go see a psychiatrist, consider medication. And I set up the psych eval and went through the whole process. And at the end of, this process, the last appointment, I was sitting in this very room with kind of Sage on my lap next to me. And the psychiatrist, I thought she was just going to talk to me and tell me what her formulation was, what her recommendations were. Instead, she insisted that Sage be with me. And then she started to say, Sage, what you have is generalized anxiety disorder. You're going to have this for the rest of your life, and there's really nothing that you can do about it. I'm also thinking about you might have autism. I'm thinking about OCD, obsessive compulsive disorder, and ADHD. And I in this chair like froze, like, oh my gosh, like what do I do? And can you hear me now? I just saw, I can't hear her. I froze in my chair and was like, what do I do? I said, Sage, you get out of here, go back and play with your Legos. Thank you. And I started to then tell the doctor, like, I don't think that this is helpful for a 9-year-old to hear this. And she started to kind of dig in around why this was important for her to understand. Well, we know from a recovery-oriented perspective that we're not just adding recovery support services to the existing treatment system. What we also need is for treatment services to be recovery-oriented. We need treatment services to be person-centered, to be strength-based, to focus on hope, to focus on possibility, to focus on all of those things and not narrowly define people by their condition or by the circumstances of their life. So when we are talking about a recovery-oriented system of care, we are talking about a transformational approach to structuring a service system that includes a range of services and support for people who have behavioral health conditions, but also for people who are maybe developing challenges, behavioral health related challenges, but also we're looking at how do we create services and supports to keep people well. A ROSC is ideally focused on the whole population. It's a population health approach to keeping those who are well, promoting resilience, building protective factors, building community recovery capital, and also putting the pieces in place that those who are experiencing challenges or have significant challenges, the breadth and scope of opportunities that were just outlined that people need in order to thrive in their communities. So when we think of a recovery-oriented system, for me, it is a value-driven, equity-focused network of services, supports, and community partnerships that all people need in order to sustain their resilience, their well-being, and thrive in the context of their communities. And one of the areas within that we often don't pay as much attention to is the importance of our unit of intervention expanding beyond individuals, beyond families, to the actual community context itself. So in a recovery-oriented system of care, our unit of intervention is not just the individuals that we're trying to support. We see the community itself as a resource for healing. And one of my mentors, William White, used to say that, recovery processes often may be initiated in treatment settings, but they are sustained in community settings. And so what we're developing in a recovery-oriented system of care is not just focusing on the treatment providers, we're not just focusing even on peer and recovery support services, we are focusing on the natural environments where people live, learn, play, worship, eat, where they do their thing. And how do we ensure that those places also are rich with recovery resources and supports so that as people are coming into contact with those settings, they also have access to supports in order to sustain their wellness. So we're thinking about a different purpose. We're thinking about a different target population or unit of intervention. And we're also thinking about this broad menu of services from treatment, recovery support services, prevention. We're thinking about early intervention, harm reduction. We're thinking about the full, array of services and supports across the system. But what we want to be careful of also is, as we're adding all of these services and supports, that it doesn't just become a checklist of, here's a gap, let's add this. Here's a gap, let's add this. That we also want to be thinking about not just what services and supports are needed, but how are the services and supports provided? And that is one of the hallmarks of a recovery-oriented system of care. It's not just a network of, a continuum of services and supports. It's a value-driven approach to providing those services and supports. So everything in the system is re-evaluated through the lens of recovery, resilience, well-being, peer leadership, peer voice, and whole health outcomes, community inclusion. And we're looking at all of the levers that we have in our system. Are they helping that cause? Are they hurting that cause? Or are they neutral? And so even our financing, our policies, our regulations, we're looking at the extent to which those things are actually advancing our cause or getting in the way. I just had a conversation with somebody yesterday who is in a system and she was talking about, and I've known her for quite a while and just walked through her journey with her, and she is amazing and has overcome so many challenges in her recovery process. And she's at the point where she wants to become a peer specialist. She can become an intern, but she's like, I can't get work because my background in the criminal justice system is preventing me from actually moving towards my goal of becoming a certified peer specialist. And when we're in a recovery-oriented system of care, we're looking at the ways in which our policies are either creating opportunities for people or creating barriers for people. We're also looking at things through an equity lens and the extent to which people are able to access culturally relevant just services and supports in places, context, and ways that are meaningful for them. So we have such an amazing lineup of presenters today. I want to be sensitive to the time. There's so much more that I can say, but just wanted to provide kind of a context, a large umbrella for us that we're talking about, as Wendy said, both mental health and substance use services. This is an integrated approach, and that we're not talking about adding services to a treatment system. We're talking about fundamentally changing the nature of our service system and also expanding our focus not to just individuals, but also the community context in which individuals, live, work, learn, play, thrive. So thank you so much, everyone. I think I am going to hand it off to Philander Moore, who is one of our champions. Philander is in Texas, and he is recovery champion, making things happen there. And he is going to talk about some of the work that has been underway in Texas, leading system transformation and ROSC-related projects for many, many years. He is one of my champions. So thank you so much, Philander.
Yeah, thank you, Tim. Good out, yeah, I guess we're in the after, we still in the morning. Good morning, everyone. It's really important in my mind to know kind of where we came from. I think one of my responsibilities here today is to just kind of talk about how Texas got to where Texas is and why we did what we did. And I think it's important for us to know where we've come from in order to know kind of where we're going. And then the whole concept around initiating ROSC and recovery support services in Texas, I guess in some ways I kind of feel responsible, good, bad, or indifferent about kind of why we started this and how we got here. One of the things that I think back on as I worked for the last 27 to 30 years in around substance use is that I noticed, in my first job with the state, is that when I went out doing what they call program monitoring work at providers that we were funding at the time. And one of the things I noticed is that people were going through what they call a revolving door in treatment because they didn't have anywhere else to go once they left treatment. Most people were going to places to get what we call Al-Anon or AA treatment at that time when they finished up treatment. So I saw a huge problem with that. I had the opportunity to attend a meeting in Washington, D.C. where I met a young lady by the name of Lynetta Albright, who was talking about ROSC at this meeting, which I thought was really interesting. When I listened to the whole concept around it, I said, wow, that's something we should try to do in Texas. But not suggest that Texas didn't have some people trying to develop recovery support services. And I think the first thing that comes to mind is there was a couple of programs here in Texas, Communities for Recovery, Joe Powell's program in Dallas, Ben Bass had a program, and a guy by the name of Dylan West had a program in Houston as well. And one of the things that I thought about after she was talking about the whole concept around ROSC, she mentioned that SAMHSA was funding a grant for us. So I thought about it and came back to Texas, and I talked to some leadership at HHSC about us applying for this grant. And they agreed to allow us to do that. So I met with some community people, which included programs like the Houston Council, Santa Maria Hospital, the Center for Wellness and Recovery, to try to put on what we thought could be a good grant project that we could submit the application for. We did all that, didn't get funded. And all the work that went into that, I felt really bad about the fact that we couldn't try to shoot a pilot out. So I got leadership to give us some funds to try to put on a workshop, if you would call it, or a coalition meeting where we brought these people together who understood more about ROSC. Like we brought some people from Connecticut who was developing ROSC. So from that, we went on to develop what we call what's being referred to as now as recovery ROSC coalitions. because when you think about ROSC in terms of what the concept is, it works real well in a smaller community, I would imagine, but we had 254 counties in Texas, so 264. And to try to develop that concept and keep people connected was going to be a challenge. So what we did was we went around the state with a group of diverse stakeholders, including myself, some of the state staff, to talk to communities about development of this concept of ROSC in their community. So we went to some of the major cities, and we started out, you know, it was kind of rugged because a lot of people saw it as being something that was going to change everything about what they were doing, but we had to sell them on this idea, and we were able to get that done. So we have a number of coalitions, and I'm pretty sure that when Javier comes on, he can talk about where they are in terms of numbers right now. But that was kind of what we did in the development of ROSC. Now, that all started back in 2010, and again, we didn't have the initial funding to try to, but again, the idea of ROSC wasn't about funding as much as it was about getting communities to come in and blend and work together. And we were able to do that. A lot of those programs were supported by us. I mean, we didn't try to tell them what to do. We gave them a guideline on how to set up what we thought would be a good ROSC concept. We maintained some HHSC staff liaison to work with them, and provide support to them. But we didn't try to tell them what they needed to do. That was one of the good things about it. We trained them, and we did this work for over 10 years, you know, and the organization that helped us with that was a contact we had through Achara Consulting. So that kind of helped us get to the whole concept of trying to build ROSC. From all of that came the idea of trying to fund recovery support services within all of that entire piece. We started that idea that concept in doing that and funding that in 2014. We developed 27 programs, which was a mixture of treatment, recovery programs, and some peer-run organizations. Now, and I'll say this because it was really important to think about trying to develop these programs within a treatment organization was going to be a difficult concept. And one of the things that we only had a few standalone recovery community centers that actually applied and got funding to do this work. And you know, one of the real cool things I think that came out of all this, there was a change in a lot of the leadership in a lot of these programs and the upper level leadership in terms of their vision and the way they were thinking about things. In addition to that, one of the things that we were able to do was create an evaluation through ARI, and ARI stands for the Addiction Recovery Institute in the University of Texas. They did an evaluation on those 22 organizations as we went through the first 12 months of it. And what we found from that was that 84% had reduced, 84% of the people who came into the project had no substance abuse. 76% had a reduction in healthcare costs. Housing increased from 68% to 89%, and an employment rate for these people tripled. So we knew there was some level of success that was happening from what we were doing. I would just suggest that the strategies around that was the idea that Dr. Achara and his staff, we helped introduce the idea of long-term recovery coaching, which is basically peer state connected to those individuals for up to 12 months, at least 12 months. And then that focused more around, and that focus was not just about, I'll say, recovery, resource coordination and system navigation. Instead, it kind of helped with making sure that the specific staff who was helping them were guiding them and helping them transform their lives. So having another peer working with another peer made a huge difference. In addition to that, we went beyond that, and we did some things around providing intensive technical assistance while these programs were being developed. And I kept them in what we call a development stage, so they wouldn't be looked at in terms of being quality. The quality assurance part of that wasn't creating a problem for them when the state decided they want to go out and look at them. I kept them in a developmental role for a long time. Each organization, they received several months of contact from Achara staff and my staff at the state. We did webinars and supervisor coaching and a number of different things to help them continue to develop those programs and bring them to a success. The other thing I'll just say that we engaged there was a lot of engagement with senior leadership at these programs, and as I suggested, that some of these programs have some issues with trying to make the development and the shift. But at this point, some of those same programs right now, and just to name a few, Nexus and I think there's another one, Lifetime Recovery out of San Antonio. Those programs, they went so far as to change their entire organization vision, their values, and their approach to how they do treatment, which is what we really needed to happen. They've experienced that what we refer to now as maybe a complete paradigm shift in terms of how they see the work of recovery going. So I'll just say that at this point, that work that we've done is continued on with the new staff that has taken it on. Noah Abdenor and his staff, and Javier and that group, they're doing some work to advance what we've already done as it relates to recovery-oriented systems of care and recovery support services kind of moving forward. So I'll just say from there, I will turn it over to, I think it's Javier is going to be next to talk a little bit about where we are now. And then the last thing I'll suggest is this, that, and I think Ajama mentioned this about Bill White saying that recovery can be initiated in treatment settings, but it has to be a sustained in community. One of the things that I wanted to continue to see happen is that we build standalone recovery support service, standalone recovery community centers in our communities around Texas. We don't have a lot of that. I think again, you can do recovery support services just as she suggested that Bill indicated to her. I think it's really important to build community support in the communities, recovery support community programs in the community, standalone, because it's very different from working with them in a treatment setting. So there's a lot of work that's had, a lot of outcomes and good things that's happened since I left a few years ago. But I think Javier can talk a little bit more about the success that the things they're continuing to do as we go forward. So I'll pass it on to Javier next.
Going to kick it then to the next series of folks. So if y'all will remember from back when I framed the agenda, there's now a series of community leaders who are going to reflect on the conversations we just had about Ross, given the seats that they sit in. And so with that, I am kicking it to Javier. Thank you so much for being with us and leading the charge on this next series of content.
Good afternoon, everyone. My name is Javier Soto, and before I jump into my part of the presentation, I just wanted to share, definitely honored to present with Philander and Dr. Ajama, because the work that Philander was talking about, I am a product of doing that work with the recovery support services, and being a person in recovery from substance use and mental health through the justice system. The first place I was told to go was to check out a recovery-oriented system of care in Austin. And yeah, I was fresh. I wasn't working anywhere. I wasn't even in the field. And through that recovery-oriented system of care, I got into a committee with the justice involvement. And then I became a peer specialist at Communities for Recovery, and then became a justice-involved coordinator. And so the work, it's been amazing to see the work done in that aspect. And so I just wanted to thank Philander for doing a lot of that work. So for as mentioned a little bit earlier, these ROS groups sustained themselves for many, many years, and they met in person, often monthly, in different parts of their communities, as mentioned earlier, with a number of diverse stakeholders. And these were typically substance use disorder focused, but the same groups can be formed with a mental health or integrated focus. And what we've been seeing on our statewide monthly call is a little bit more of this, more mental health stakeholders joining the call, wanting to be a part of. And so we definitely see that paradigm shift. Today, I'm going to share how we revitalized them over the last 2 years. Our strategies can help other states that are either starting these types of ROS-focused community coalitions on working or re-energizing them. And so we know that the big challenge, what we saw as COVID happened, it was an extremely challenging time. So pre-COVID, I believe there was about 25 plus community coalitions that were happening around Texas. When COVID happened, it probably went down to 5 or 6. And so As I joined the state in 2022, there was already efforts that were starting to happen with Dr. Achara and her team, us at the state, and the Addiction Research Institute. And so participation naturally decreased and the community struggled to sustain the stakeholder engagement. It went from 64% of the groups stopped meeting altogether, or they felt like they lost some steam during COVID. And so some of these other challenges were needing clarity of focus and compelling purpose. Everyone knew that they were meeting to support recovery, but that focus of area was really broad. And after COVID, we met with many of the community members. And one of the comments that we heard the most was that people were no longer clear why they were meeting, right? People were just showing up to these meetings. A lot of these meetings were focusing on lunch, and maybe the organization, the anchor organization that was hosting this was predominantly their staff, right? So the interest was kind of lost. We also heard that groups were more focused on networking and the resource sharing, but members did not feel that they were making a difference in their communities. And so many of the stakeholders attending the meetings were from the host organizations, as I mentioned. And so when I think of the components of a ROSC, as I was taught to myself, it was supposed to be people, providers, system, and community. And what we were hearing on these calls was it was mainly providers just talking around and not really getting the people who were receiving the services and the community's aspect from that. The members were not as diverse in terms of representing different community perspectives, and we were not sure that the voices of people who need it the most were being heard. So here were some of the solutions that we have implemented over the last 2 years. We as an Achara Consulting and myself, we have a statewide ROSC monthly call. We do it every last Tuesday of the month for an hour. And we are really working on trying to equip people with the tools and skills to discover and reconnect the needs and desires of their community stakeholders, and to conduct assertive outreach with the underserved groups. We did this through providing them with training and technical assistance around community engagement. And so myself and Jen Sears with Achara Consulting started having more one-on-one strategic calls on some of our off months, like recovery month. We don't have a call during recovery month just because we're having some rallies all around, which I will talk in a little bit. And then November and December, it being that it's the holidays, the way that we utilize a lot of that time was having 30-minute to an hour slots and really inviting the community coalitions to kind of talk. We can be a soundboard. What are some of the struggles? And we've seen some breakthroughs with a lot of these emerging or re-emerging community coalitions. Each ROSC community group was offered support on how to conduct focus groups and community listening sessions so that they can get a clearer sense of the needs. And so not all of them chose to participate, but many did. Through this process, they were also encouraged to think about who had not been at the table. This is a time for them to reflect, okay, we have a lot of our providers at the table and some systems, but where are the people who are needing the services? And so we partnered with SAMHSA, funded African American Center for Behavioral Health, to create a guide for the ROSC groups on how to engage underserved populations. We also walked with them through the entire process of developing questions, identifying locations, sharing roles and responsibilities among the coalition and the coalition members. Another huge thing that we started to leverage during COVID was technology. We, at first, the last 2 years, as these coalitions have became reemerged, we started to ask, how are you all meeting in person? Are you doing virtually? And so a lot of these community coalitions started to do it simultaneously where they would have some in person and some virtually. And I know for the larger cities like Houston, San Antonio, Dallas, where it's hard to get from one place to the other during maybe that call, they can tune in via virtually. And so they were still staying connected that way. Another way that technology has been leveraged is having a sign-in or a QR scan. And so this was mentioned on one of the calls where they were able to get not only contact information, but they were also able to ask, what is the greatest, what are some struggles? What are some accomplishments? How can the ROSC benefit you? And who wants to present and those types of things. So really leveraging technology in many different ways. Some of the outcomes that we have gathered, we did a survey at the beginning of this year. We just wanted to get a pulse on what was happening. Were some of the topics that we were bringing being helpful? Were some of the strategies that we had mentioned, was that working? And so what we gathered was 72% reported that they are meeting more consistently. Nearly 30% of growth in the number of recovery-oriented system of care community coalitions had happened in the last 2 years. And there was also an increase in number of engaged stakeholders. For example, one went from having 5 staff internally to the organization meeting. As I mentioned, it was all staff, to a meeting of over 300 stakeholders that were engaged. Another outcome was increased diversity in membership, increased clarity in purpose, expanded communities and partnerships, and in the planned community events. And so this is kind of going to roll into some of the successes that we have had in the planned community events. So as mentioned, it is National Recovery Month, and there are 15 recovery rallies that are happening in Texas this month. And that was organically happened during this uptick of recovery coalitions. And so again, that was just something that spread up organically. Now, so some of the numbers that Philander had asked about were, how many coalitions do we have? And at the moment, we have 17 community coalitions. We have 11 regions in Texas, and we have at least 1 or more community coalitions per region, and growing. We are scheduled to have a few more of these strategic calls with some of the community coalitions that are wanting to start a ROSC. And we've seen a few go from, as I mentioned, 5 in December of 2022 to that 300. And it was just really meeting with them strategically and helping them grow in that efforts. The other amazing thing that happened within the partnerships is we have these rallies that are happening all around Texas, but the first ever Big Texas Rally for Recovery is happening at the Texas Department of Criminal Justice. And that's happening the next week, and then another one in October 19th of next month. And this is all kind of happened organically. Nothing was forced, but it was the need that has been brought up. And so I wanted to just share with everyone. I will share just a few more, and I've gone a little bit over time. The governor of Texas, the mayor of Houston, and Harris County judge released proclamations to announce their support of the Big Texas Rally for Recovery and declared September Recovery Month. And then just, I want to share 2 successes from local. I know Dr. Kirsten Harper, or Dr. Kristen Clancy will be sharing a little bit more about the Houston Recovery Initiative. But with the Alamo ROSC in San Antonio, something that came up in one of in their calls, in their monthly calls, was having more wellness in their area. So they went around, they connected with a local gym who offers free classes to their community, and they've seen a huge uptick of just having people go. be a part of that local gym. Another goal of theirs was integrating a sobering center. And so we've connected them with the Austin Sobering Center and the Sobering Center in Houston. And they've traveled across Texas to ask what were the challenges, what has been helpful, and in part for them wanting to maybe open one in 2025. And so they've had a lot of advocacy planned to speak to local and state leaderships for funding. And the last one is in Abilene, there was during a few local ROSC meetings, it was brought up that there were no city showers for the unhoused population. And after bringing that up on some of our strategic calls, we just gave some ideas, and they worked together and came up with a solution to invite an organization that had traveling showers to meet up at a park so that the community can utilize those showers. And these are just a few success stories. There's many, many, many. Not enough time to speak on those, but I just wanted to share how these partnerships are working organically, and often we don't get to hear a lot of the amazing work that is happening around the state, but we do know that involving that communities, providers, and especially the people receiving services to their local community coalition, it benefits the system of care as a whole. And with that, I believe I'm going to pass it to Mr. Jamie Whitaker. Thank you.
Thank you so much, Abigail. You know, listening to all the amazing things that are being shared, it's so inspirational to realize that, you know, if we can come together, you know, as leaders, as providers, as people who've experienced the systems and experienced the resources that are there for the help, if we can come together as community, I love Dr. Chura talking about it so much, like, you know, the idea of community. And I think that, you know, I'm a product of system of care. I am a product, and the only reason I'm doing the work that I've been doing for the last 15 years is because our state came together and began to talk about, you know, what does it look like to have a recovery-oriented system of care? What does it look like to begin to bring people to the table with lived experience? You know, I'm a person in long-term recovery, person who lives with mental illness every day, successfully, happily, and thankfully, I'm very, very supported by people in our state and by our recovery-oriented system of care here in Indiana. So again, my name is Jamie Whitaker. I'm the Vice President of Forensic Services here in Indiana. And my job for the last 15 years has been working within recovery-oriented systems of care here in Indiana on various aspects of that. I started this work working with youth back in, let's say, 2012, 2013. We were beginning to have our systems of care conversations around the idea of building better resources and better services for our youth here in Indiana. And then really excitingly to watch, you know, around 2016, 2017, Indiana had grown our recovery-oriented system of care work from, you know, 7, 8 counties that were doing it. We have 92 counties here in Indiana. From 7, 8 counties that were doing it all the way up to where we had 79 counties out of the 92 that were engaged in recovery-oriented system of care work. And through these developed and interconnected conversations here in Indiana, we were able to really build an infrastructure that once we started moving into the scope of moving from both youth work into adult work and talking about, you know, how fentanyl, how the substances that were hitting our streets, how it was impacting our people who are struggling with substance use and people who are struggling with mental health. Late in 2017, 2018, we began to look at building infrastructure here in Indiana around recovery community organizations. And what does it look like to put the peer voice really at the table? We love this saying that I know I've heard lots of people share this, you know, nothing about us without us. And, you know, I love it when I hear Dr. Chura talk about, you know, what does it look like to give everybody a seat at the table? You know, what does it look like to have your values drive the work that you do together? And part of that value being that everybody is included, that everybody has a seat at the table, and everybody is able to come and give their thoughts and voice. And it's only through having those strong collective voices where everyone has representation at the table, are we able to really talk about the challenges we're facing in ways that are, and then adapt ourselves and adapt our ways, our procedures, our processes, our resources in a way that can become effective and allow us to really deliver effective supports, services, and resources so we can have, better health, better home, better community, and better purpose for our people here in our states. As someone in recovery, I can tell you that when I went through the system, these kind of things weren't there. I think the biggest thing that I felt when I went through the system was that I don't think anybody ever heard anything that I had to say. I didn't have a voice. So to have our systems and providers, both from leadership all the way from the very top, like here in Indiana, we have Governor Holcomb, who, we're so grateful for federal block grant dollars that come down and how we're able to use those block grant dollars from SAMHSA to really adapt and build great infrastructure. So we moved into, taking these conversations and taking these community conversations in a deeper way and talk about, okay, now that we've got people at the table, now that we're beginning to come together and peers are getting used to sitting down with judges and commissioners and mayors and state leaders are getting used to sitting down with peers and law enforcement, and we're all at the table having conversations. Now that we've gotten used to that new adaptive challenge, what are we going to do now? What can we do with this system? And I think taking the values behind, a TI-ROS model and driving those values and saying, okay, how can we build better infrastructure? Well, what do we need? Well, we need more peer infrastructure here in Indiana, and we knew that. So we began to, thankfully, from Division of Mental Health and Addiction, which is our leading mental health agency here in Indiana, was so grateful alongside our governor. They put a lot of those block grant dollars in funding a peer statewide infrastructure of RCOs here in Indiana, which allowed us to make sure that everybody had access, to a place that they can go, a place that they can feel safe, someone that they can go and get help with, and allowing that, that next step in the conversation of infrastructure, like making sure that peers are at the table and that these RCOs, these peer ecosystems, were available for folks no matter where they lived. That was a key step for us here in Indiana, and taking our work and allowing people to have access to those resources no matter where you lived. And we have a lot of rural counties, as I'm sure lots of states do. But so having those resources was very vital and important. Then we began to focus our next set of efforts into building peer certifications and how can we professionalize the work of peers here in Indiana, both by building efficacy and making sure that we're saying, okay, what are our ethics? What are the ethics that peers are going to abide by? Can we all agree? Can we all come together and decide what that is? What do the roles look like for peers? And what does it look like to build peer infrastructure and have peer professionals in our state? And getting feedback from everybody, from judges, because how a judge is going to see it is different than how a law enforcement officer is going to see it, is different than how an ER doctor is going to see it versus a mental health professional. So having all of those conversations, we began to build more peer infrastructure around having certified professional peers, and then making sure that we had an efficacy or an ethical way of evaluating ethics here in Indiana and providing people support and education. So we're very lucky that we were able to build that at that time. Then, of course, we had the pandemic, which was a fruitful, fun of time for everyone, I think. But I can say that we were very, very excited around that time to be able to take and move our peer efforts to like the next level. And having strong community conversations and having people where everybody is at the table and everyone is using their own values to drive the work that we're doing together, and that collective community that we have within that TI-ROS model. I don't know how well our state would have made it through the pandemic. There are jails locked down and no one was going in, courts were shut down, people in recovery didn't know what to do. So we had some real challenges on what we were going to do next. And so we began to invest in crisis response teams. So again, another place where we can build out, use our TI-ROS model in those community conversations to say, here's a gap, here's a resource we can put in to fill that gap that can include our mental health professionals and our law enforcement officers and peer recovery coaches, and everybody is a part of the system. And now we have a new gap filler here in Indiana that is meeting needs in a new way. And so we were, as we look at this, we began to realize that, you know, there were other great things that we could put inside of our TI Rocks that we felt like would drive and allow us to be more specific about some of the conversations and the gaps we're seeing. Because the coolest thing that happens in a TI ROS or in a ROS model, once you start finding success, everybody starts saying, what else can we do? Now, what else can we fix? Or what else can we do now? And you start seeing people get excited about creating system change and really allowing things to be effective and efficient in ways that they've never been before. So we said, okay, what can we do now? And we began to look at sequential intercept model as a way of putting that inside of our TI ROS conversation and saying, okay, how can we identify the gaps in our services? And one of the big gaps we had after that was obviously our jails and our prisons, people coming back from reentry. So again, we began to kind of next step the conversation, say, okay, what can we do in this space? Because obviously there's a gap for us here for people who are both incarcerated and people who are coming back into reentry. And we were very lucky in this way because we've had so much success and because so many people are at the table having conversations. Again, those state leaders took some more of these wonderful block grant dollars we got from SAMHSA, and we've put that money down into something that we call IRACS, which is our integrated reentry correctional support program here in Indiana. And we started off with 5 counties, and this is a really intensive approach where we take groups of peers and put them right in the jails and right in the prisons. We started going into the prison and training people in the prisons to become certified peer coaches, and then building stronger collaboration between our treatment providers and correctional staff and corrections officers and law enforcement and our peers here in Indiana. So what a great space for us to, again, identify another gap here in Indiana and to say, okay, how can we use our ROS conversation to find solutions to this problem? I'm going to brainstorm. So we did the whole storming, forming, norming, performing, and trying to figure out exactly how we solve these challenges. And we were able to come up with a program that everybody agreed from the top down across all the systems that this was a great way to build into our system and create a gap filler that's going to provide support for people as they not only while they're reentering, but also as they're getting prepared to reenter. As we know, the saying that the peers use here in Indiana when we talk about our judicial system and we talk about incarceration is that reentry should begin at day one. And that if we're waiting until people are leaving jail to begin to have conversations about what they need, we're way too late in the game. So we should start talking about what people need the moment they're involved with the justice system. We should start preparing for them leaving incarceration, leaving the justice system. And that way we can try and keep them to stay out and create that true safety net. And I think one of the, and again, I could probably go on for the next half hour about this stuff, but I'll just like 2 more points I want to focus on about ROS that I think is so amazing. One, I think that was so great about our ROS was through our criminal justice efforts, we began to see people come to the table who never really saw themselves as having a seat at the table. When you see jail officers and sheriffs and law enforcement officers coming to the table when normally they don't really feel like they have a voice, they don't really know where they fit in this picture of creating solutions because they just felt like they're housing people. And to empower our sheriffs and to empower our jails and prisons and being able to come together as a state and as a community, as a system of care and provide resources that empowered our jails and prisons to feel like they could become a part of the solution and that everyone was behind that. That was the most transformational thing that we've ever seen, that I've seen here in Indiana in the years I've been involved with this work, and that's going on 18 years. And so we see jails and sheriffs now saying, you know, here's how I know I can create solutions for people so that they don't come back to jail. They don't have to see them anymore. And they see that working. And then now, once again, we have people saying, well, this is so fantastic. We were able to do this, and we were able to do this, and now we did this, and now we did this. What else can we do? How else can we build this strong community? How else can we build these resources that are going to help people? And what a great way to provide support for people. I will tell you that, you know, wherever your state is and this idea of recovery-oriented system of care, wherever you are in this community conversation, the most important thing is to look at the values that are driving the discussions that you're having, and then make sure that everybody in your community realizes that everybody's voice is needed and that we all need to be a part of this conversation and continue to drive that valued conversation. Because the amount of resources, the amount of this peer ecosystem, this recovery ecosystem you're able to build because of that is so incredible. It can be so life-changing and transformational for people. We're very blessed here in Indiana. I feel like we have an incredible ecosystem. We have great leadership support us. And I've seen the value of peers continue to grow and grow and grow. And I'm so excited and grateful to not only be a part of that work, but to be here to share this with you here today. And so thank you so much for your time. And I get the wonderful opportunity to introduce you to Dr. Clancy. So I'm going to pass off to Dr. Clancy. Thank you so much.
Fantastic. Thank you. Thank you for the introduction. I'm so honored to be here during Recovery Month and Suicide Awareness Month and be recognized as a local leader in recovery. That's just fantastic. Thank you. My very short story, I was T-boned in a car accident before I started pharmacy school, spent 8 years navigating chronic pain management during the time when we now recognize that there was a lot of over-prescribing and over-dispensing of controlled substances, and ended up becoming addicted to fentanyl specifically. And I think back to that time, in 2014, I thought my life was over, my career was over. What would I have to offer anyone ever? And my story really was just beginning, right? In 2014, fentanyl had not yet infiltrated the drug supply. And so if you have a program and you have a higher power, I recognize now that my higher power was starting a really good story. So as a pharmacist, I had the privilege of going to one of the top 5 pain management rehab facilities in the country at the time. I worked for a hospital system. I had great health insurance. I had a pharmacist bank account. I, jumped in 10 toes in the water and completed treatment. And then I had the opportunity to essentially meet with the ROSC where I was living and apply for Medicaid and apply for food stamps and apply for assistance so I didn't lose my house, and get set up with therapy, all the things that are so essential to the fact that I'm just alive today, right? Having access to those resources. Even as a pharmacist, I'm not an expert on what resources are available in the community for people that need assistance in recovery, need assistance for housing, employment, healthcare outside of pharmacy. So I had an incredible learning experience. And when I took the peer recovery coach class at the Council of Recovery in Houston, Cynthia Branch, who is here today, thank you, told me that I needed to go to the ROSC in Houston and get plugged in. And so 5 years later, I'm here as the director. Javier made a great point that there were 27 ROSC community coalitions in the state of Texas before the pandemic. And we dropped down to 5 active ones. And I attribute that to the fact that the Houston Recovery Initiative maintains a paid staff leadership model, in that my role and my program manager's role has been paid for initially by the grant that Philander mentioned, and then the Houston Endowment Fund through funds from the city. Currently, we have a grant from the CDC and CDC Foundation, and certainly private donors, and a lot of in-kind contributions in our community. The issue that we have in Houston has the highest overdose fatality rate in Texas. Texas has the 3rd highest overdose fatality rate in the country. We got there because there was an interruption in the Narcan supply that had been paid for by the state. There was about a 6-month period where those supplies were not available, and we jumped from number 5 to number 3, and we've never recovered from that. And I think that is a really good testimony of what happens when you have an interruption to services. And I honor the spirit of community-based coalitions, bringing together people out of the kindness of their hearts to share in the experiences like I've had. But the individuals are also going to suffer the same consequences of the community if there's a pandemic and there's interruption. Houston itself is 50% Hispanic, right? I want more diversity in leadership. I want more women in leadership positions, especially lived experience leadership. But those individuals are statistically underpaid compared to their peers, right? So in addition to working their job, they may be working another job. And then I'm asking them to have time out of the kindness of their hearts to come volunteer. It's a very challenging model if it's 100% volunteer based. I want to maintain consistency. I want to maintain the same faces. I've been working for the Houston Recovery Initiative for 5 years now, as has my program manager. People know us, right? I grew up in the Houston recovery community. People know us from that. And that lends to the credibility of our organization and what we can provide to individuals. And if that is interrupted, then people will tend to not even look to the ROSC as an opportunity to connect them with services because they don't know who's there anymore. The last time they reached out, it didn't work. Whatever the instance is, if there's constant turnover because it's volunteer based, then we are going to have an interruption in the system. I feel like the opportunity that we have here is to recognize the innovativeness that the ROSC models serve. There's no treatment facility in Houston that provides assistance with housing and healthcare and employment and specialty groups for vulnerable populations. Back to the diversity, patients will, in the healthcare setting, patients will have a better outcome if their provider is from their culture, right? Speaks their language and looks like them. And if we are not supporting those individuals to have leadership, visual places in the ROSC recovery model, then it doesn't have the same impact as it does on our white peers. I truly want to reach individuals where they are at. And to do that, I have to recruit and maintain individuals outside of their employment and help pay for their time. These are experts in the field. They may have 20 to 30 years of experience. They're very valuable members of the community, but they are also human beings and they have to make a living too. One of the benefits of having a consistent ROSC during this time is that the work groups and members of the Houston Recovery Initiative could continue to provide the services that they were before the pandemic. And they didn't have to worry about, well, who's got the Zoom account? How long is it going to last? What if I have a meeting the same time as another meeting? How am I going to email people? I would like to apply for a grant. How do I do that? We assist them with the technology, with the behind the scenes assets that they need to run a group that they may not be an expert in. And as Javier mentioned, we are continually learning and growing. We have over 1,000 members now, and we've outgrown our email system. So we're looking for a new one. We're going to be using our meetings and establishing them as an echo community and providing those webinars to train other individuals. That's an upgrade in technology. It's an amazing place to be. I hear it all the time that the Houston Recovery Initiative really is the gold standard for the ROSC model in Houston. And I'm so honored to have been someone that benefited from that. I'm honored to be someone that has helped carry it through difficult times, and I'm incredibly honored to help it to grow and to be everything that it can be, not just for HRI in the Harris County area, but also for any other ROSCs across Texas that are in need of re-energizing. I actually had an academic from the original ROSC that helped me reach out to me and ask me to help reinvigorize that coalition. This life is so incredible, and I'm so honored to be a part of it. And thank you for letting me share a little bit of my story.
Dr. Clancy, and their story was beautiful. And we also thank Jamie and Javier for those wonderful reflections about kind of how this really sits with them here. With that, we're going to shift to the next part of our content, and we're going to have updates from our federal partner, SAMHSA, and then from NASHPD. So I'm going to move the mic to Audine Watson. So glad to have you, Audine.
Thank you, Wendy. Good afternoon, everyone. I'm Audine Watson from the Center of Substance Abuse Treatment, and I am the ACOR on the SPARK contract, and we provide support to the Office of Recovery. And I wanted to let you all know about a number of events for the rest of the SAMHSA National Recovery Month. So next week, during September 15th to the 21st, is week 3 of National Recovery Month, and we have a few webinars on Monday, September 16th. We have Nothing About Us Without Us, Family Support and Recovery. On September 17th, Recovery on Purpose from 1 to 2 p.m. And then the Interface of Peer Support and Person-Centered Planning on September 19th. 1 to 2 p.m. And again, you can access all this information on SAMHSA National Recovery Month page, which has been posted in the chat, as well as we have the digital Gallery of Hope. It's artistic expressions of recovery across the nation, featuring 280 selected artworks, and it's open for viewing until the end of National Recovery Month. And they also have posted the Gallery of Hope link into the chat. So please go and visit that. And then on September 24th, very exciting, the SAMHSA Trailblazers in Advancing Recovery Award ceremony will be honoring leaders in recovery with lived experience of mental health and or substance use conditions, including youth and family members whose lives have also been affected. And you will be able to join the live stream of this event on HHS TV the day of the event, and that link is also posted in the chat. All right, and now I will hand it off to Samara.
Thank you, Audine. Hi, everyone. My name is Samira, and I work at NASHPD under the TTI team. And I'm just here to provide you with a quick overview of, or a quick update on the new TTI application for 2025. So if you don't know, the TTI is an annual flexible funding opportunity from SAMHSA in collaboration with us at NASHPD. And it's here to assist states in transforming their mental health systems of care and territories as well. So I'll go ahead and paste this year's topics into the chat. So it's 6 topics that were just announced. Right, oh, pasted kind of weird, but there are the 6 topics, and these are based on needs that states and territories have shared with NASHPD. And SAMHSA is funding 48 TTI awards of $250,000 this year. So these are fixed price contracts, and these are on the following 6 topics directly related to implementing and expanding 988 and crisis services. So the first one is community-based service approaches for justice-involved individuals with severe mental illness or severe emotional disturbance. Second one is community crisis system mapping and implementation. Third one is crisis care and suicide prevention for underserved youth. The fourth one is crisis workforce wellness and resilience and prevention of burnout. And the fifth one is training and professional development for the non-clinical crisis workforce. And last but not least, the sixth one is treatment and supports for children with high acuity and/or complex needs at risk of out-of-home placements. So states and territories can apply for and receive multiple awards. And it's worth noting that these applications would have to come from your state behavioral health authority. And all proposals must focus on serious mental illness and/or serious emotional disturbance populations, as well as providing a focus on folks with lived experience in planning and implementation of the initiative. So you can see more examples and information in the application package that I will drop in the chat right about now. And you can go ahead and take a look at that. There we go. And so states and territories, you all can go ahead and send your proposals back to NASHBID. The emails are linked in the document that I dropped in the chat. And the deadline is Monday, October 7th at 5 p.m. Eastern, or by 5 p.m. Eastern. And so during the TTI itself, your team would be offered intense TA interaction from or until August 2025. And the TTI allows states to continue their work far beyond their contract conclusion in August. And during the TTI, the recipients will receive one-on-one support from subject matter experts on a wide variety of topics who work to guide and advise all TTIs on their ongoing efforts. So these subject matter experts will be of your choice, but NASHBID will perform all the coordination, do the heavy lifting, and use NASHBID TA funds to contract with the SME directly to avoid any state procurement delays that are very common. You'll also have access to learning communities of other states and territories who face the same challenges. So all in all, it's a fairly easy and flexible award, and we encourage you all to apply because the deliverables only include a report once a month, so generally 10 reports in total, and a call with us once a month. So it's flexible, straightforward, and if you have any questions, feel free to reach out to any of these emails that I'm about to drop in the chat right now. And you can email me with any questions that you may have. And thank you. I'm going to go ahead and pass it back to Wendy.
Thank you so much. And I do just want to say, since NASHBID was the last presenter here, we also just want to extend gratitude to Amy Brinkley, who's also been such a partner in all the Sparking Recovery events planning. And so I wanted to say thank you for NASHBID in allowing her to support this as well. So with that, everyone, we are getting ready to wrap up our time together. And we are just really grateful to all of you who stayed with us throughout this process, and the value of just the speakers and their amazing lived experience and their partnership on this work. And coming together today to help all of us in whatever community in which we sit to continue to advance recovery work as well. And so everyone stay tuned because in a quarter we will be back with you with other amazing presenters around other amazing recovery work. And so again, we thank SAMHSA, we thank our presenters, and I've been honored to be your facilitator today. Thanks to everyone, and I will hopefully see you guys in a quarter. Take care and be well. Happy Recovery Month.